Well, good evening, everyone.
Okay.
Okay. Harvey's already started the program, so I'm Susan L., Vice President, Executive Director of the Foundation, and I am really happy to welcome you here to this program. We're proud and privileged to bring you another very informative evening. There's a lot of interest, a lot of high interest in our topic to this special edition of the Leading Edge Medicine series. One of the reasons I look forward to this is really because of you. All the buzz and the conversation that was in the room just a minute ago tells me that there's enthusiasm and interest in this topic, but it also reminds me of how very special our donors and our friends, our board, and our physicians are to us. As partners, we know that so much is possible when we work together. So thank you. Thank you very much for your interest, for your support, and for being here this evening. Now, before we go much further, it's my privilege to recognize some of our foundation board members who are here. They have the silver badges on, and if you haven't connected with them, please do. As the sponsoring body of this event, they take every opportunity you can to meet with them and talk with them. Our hope, the foundation's hope for you this evening, is that you learn something new, that you connect with friends and make some new friends, and embrace the innovation and discovery that is making life better for all of us. Tonight, it's an exclusive opportunity to hear firsthand from the physician scientists who are truly on the leading edge of science and medicine at Barnes-Jewish Hospital and Washington University School of Medicine. This is a critically important topic that we're discussing this evening. Addiction medicine and the opioid crisis is impacting thousands of families right here in St. Louis, all across our country and around the world. Every day I asked one of the doctors just to make sure that I was given the right statistic, but every day between 5 and 10 individuals come through our doors at the emergency department in an overdose situation. Every day at our emergency department at Barnes-Jewish Hospital. And that number continues to grow. Barnes-Jewish Hospital and Washington University are not just sitting on the sidelines, and our experts are stepping up to help solve this epidemic while caring for those who are affected and impacted in this crisis. It takes leadership, vision, commitment, and it takes resources. Many of you have heard me talk about the foundation being a fundraising organization, being a grant-making organization, and also being a community partner. And that's why we gather here this evening under that mission of community health and community. We are an active community partner in this endeavor and many others in the health of our communities. So we are so grateful that our generous and compassionate donors share in our mission to provide help where and when it's needed. Your philanthropic investments through the Foundation for Barnes-Jewish Hospital improves lives wherever you direct your gifts, whether it's to Barnes-Jewish Hospital, Barnes-Jewish West County Hospital, Siteman Cancer Center, Goldfarb School of Nursing at Barnes-Jewish College, BJC Home Care and Evelyn's House, or Washington University School of Medicine. Today, your support is truly needed, and you're about to learn and hear from our physician presenters who are with us tonight. Each one brings a unique perspective and area of expertise as they collaborate to tackle this opioid crisis from every direction: mental health, emergency care, and prevention. We can help these physicians remain at the forefront of the charge. And to introduce our featured presenters, I am very pleased to present Bob Cannon, President of the Hospital Group, President of BJC Healthcare, and President of the Foundation for Barnes-Jewish Hospital. Bob.
Thank you, and good evening, everyone. There are some prepared remarks that I have here that I'm going to go through, and then as I sometimes do toward the end, there's a few extra things I would like to add, which often makes the staff here really nervous. But we really are in for a treat tonight. So first things first, just thank you. Thank you for being here. Thank you for your generosity and the gifts that you give to the foundation. I often say that of all the things and all the support you need to run a hospital like Barnes-Jewish, none is as important as the support of your community and of your donors. So please know that everything you do and the time you give us, the sharing of your hard-earned resources to support our mission makes a huge difference in the lives of many every single day. Tonight's topic really is critically important. We're going to all benefit from getting to know more about it. Opioid overdose deaths have quadrupled in the last 2 decades. On average, more than 134 people in the United States die every day from opioid overdoses. In the Midwest, opioid overdoses increased 70% in 1 year alone from 2016 to 2017. And as Susan mentioned, 5 to 10 of these patients come through our doors every day at Barnes-Jewish Hospital. This is a public health crisis of really epic proportions. The people affected come from all walks of life. It's a cross-section of society in the suburbs and the cities and our schools and our workplaces, and our community is crying out for help. So thankfully, we have a team at Barnes-Jewish in the Washington University School of Medicine who is devoting their very best efforts to tackle this crisis head on. Our team tonight is really at the front line of the opioid crisis, and they're doing work locally that is impacting the national debate and the national movement to fight this opioid crisis. So we're privileged to have with us here Dr. Laura Bierut, who is a Washington University psychiatrist, director of the Health and Behavioral Research Center. She's leading several studies to understand the genetic causes of addiction. Also joining us is Dr. Rob Poirier. He's clinical chief of emergency medicine and director of the Emergency Department Patient Safety, Quality, and Performance Improvement. And then another physician joining us tonight is Dr. Evan Schwarz, Washington University addiction specialist, emergency medicine physician, medical toxicology section, sorry Evan, and director of the Outpatient Medical Toxicology and Addiction Medicine Clinic. So these are our 3 experts who will share their perspective and what is working well and what is being done to combat the opioid epidemic across the country. Now, here's the part I wanted to add. The Emergency and Trauma Center at Barnes-Jewish Hospital is one of the busiest in the country. And every day, these 3 individuals experience and support us firsthand in seeing a myriad of society's issues that come to our doorstep. So whether it's the opioid crisis we're talking about tonight, the ravages of gun violence in our community, the overwhelming mental health and behavioral health challenges that are seen in our community, the diversity of patients that seek our care. These are the individuals that are every day putting themselves in the moment to take the very best care of our patients and their families who come to seek our care. So as we welcome them to the podium here, I would just like to ask you to join me in applause, both for what you're here tonight, but for all that they do each day. Ladies and gentlemen, thank you. The podium is yours.
Get up and walk around if you want.
Great. Well, thank you for having us and letting us speak to you on such an important topic. So I think to start out with, I think just talking about the numbers in general, so unfortunately you can really see the scope of things is really important. So we'll start with the US data. So this is in 2017. We unfortunately had 49,000 Americans die from an opioid overdose. To kind of put that in a little bit perspective, if you look at the number of Americans that died in the Vietnam War, or the number of Americans that died at the peak of the HIV epidemic in 1995, they were in the 50,000s. So people we lost just due to opioids have almost equaled both of those total, and the number unfortunately keeps climbing. If you look at the numbers in Missouri, it very much echoes the same type of pattern as far as continued opioid deaths. And you can see that here, where in Missouri, we're one of these dark states here, which are one of the top third in the country of victims of the opioid overdose crisis. Once again, as Bob Cannon said, opioid overdoses increased 70% in the Midwest, and we're definitely seeing a lot of those in the emergency department.
Why is that?
Why is there so much?
Why are we in the upper third?
So we're trying to figure that out still. Some of it is, as we'll talk about it, is under treatment is definitely a big deal. We also are now seeing more fentanyl and other of these really potent opioids coming in to our area just because of transportation into the middle of the country, as then they head out to other places in the country. But there's probably multiple reasons that we're still trying to wrap our head around some of them. And as Missouri's going up, kind of St. Louis in this area drives what we see in Missouri. So as you can see here, if you look at drug-related deaths per 100,000 people, in Missouri, the average is 22 per 100,000. If you look in St. Louis City, that's 69 per 100,000. So we're really at ground zero. What happens here translates into what's happening in the rest of the state. And so if you only remember two things that we're going to say, really, if you only remember one thing, I want you to look at the last slide that Dr. Bierut talks about. But if you only remember two things, it's as bad as these numbers are, most patients aren't in treatment. So probably throughout the country, about 80% of people that need treatment don't get treatment. In St. Louis, as staggering as these numbers are, we're talking about closer to 90% of patients that could use treatment aren't getting the treatment that could potentially save their lives and save loved ones' lives. And one of the reasons people aren't getting treatment is there's just not enough providers. So the mainstay of treatment for opioid use disorder or opioid addiction has been methadone for a long time. In 2002, legislation passed that let us use a medicine called buprenorphine or Suboxone in order to treat these individuals. And what was really nice about it is it had a better safety profile than methadone, but it also allowed individuals to get treatment in lots of different places. So because of this, we can easier treat people in the hospital, treat people in clinic, treat people out of the emergency department. In California, there's actually vans that go to different places and actually treat patients that are living in parks and things like that. So it's really increased our ability to do this. One issue is in order to use buprenorphine for addiction management, in order to prescribe Suboxone, you have to have something called an X waiver. In order to get an X waiver, you literally have to sit through 8 hours of education and keep all these fancy logs. And then even in your first year, you can only prescribe to 30 patients. It's actually capped how many people you can treat. And you see how the numbers are. And so even if everybody had a bunch of these waivers, it would still be hard to treat everybody. But unfortunately, even though we've had access to being able to do this since 2002, this is 300 people have an X waiver in Missouri. And in St. Louis City, only 55 people in nearly 16 years have gotten an X waiver in order to be able to treat these patients. If you look at how many people are actually prescribing to their limits, it's even less than that. There's quite a few individuals who get their waiver and never use it or prescribe to 10 or less patients. And without this, it's really hard to treat these patients. And these are ways that we could potentially change these patients' lives, change people's lives, get them out of kind of this really hard to live with existence, and they're just not happening.
So that brings us up to 2016 at the end. As the clinical chief of the emergency department, I watched the numbers every day and the chief complaints of people coming in. And we noticed that the overdoses were spiking up. People would drive up to the front of our door, throw out a body. We would find out, oh, heroin overdose. We would immediately give them the Narcan, bring them inside, get them resuscitated. That was happening very often, several times a week. And EMS as well would be called in some instances. But people are sometimes afraid to call EMS because sometimes the police come and then they're worried that they're going to get put in jail or the judicial system is going to get involved. That does not happen in our area. But we have to break down some of these biases and these misconceptions that are out there. So at the end of 2016, we started a program called EPIC. There was some federal funding that came into each of the states throughout the country. It passes through the Department of Mental Health, and we have a couple of agencies within Missouri that help distribute the money itself and the resources. So we started a pilot project called EPIC, and it's engaging patients in coordinated care. What we found is, in the past, and for 15 years before this, practicing emergency medicine, when somebody with an overdose came into the emergency department, we would resuscitate them, give them a piece of paper, and say, call a number on here and try to get into rehab or follow up. The problem is that doesn't work, because the way addiction, especially with heroin, works is that as soon as we reverse the effects of the opioids in somebody's body, all of a sudden this craving overtakes them. And so it was not uncommon, once we reversed the effects of the heroin, that they would immediately go back out and start shooting up again. Or they wouldn't even make it out of the emergency department. We had people shooting up in our bathroom, the public bathroom, right in the waiting room. Fortunately, we were there to resuscitate them again. A bunch would go out, and we'd see them a couple of hours later coming back in. That addiction is so strong that they immediately want to go back out and get to where they were before, because we reversed it. But unfortunately, when you take too much of the opioids, it shuts your breathing off and you don't breathe. And if you don't breathe for 6 minutes, you can then die. And that's what happens. That's what kills people with the opioids. So we started this EPIC program as a pilot project. We started at the BJH emergency department. And what we did is, when we had somebody that came in with a heroin overdose, we would call a recovery coach in. And so we set up a program where we just had to make one call. Often it's done through our social worker. The recovery coach, who is a former heroin addict, most often, or an opioid abuser, who's now clean and has, and they're oftentimes reconnected with family and friends, because before they were ostracized. And they will come in and speak to our patient. I can speak to the patient, but because I'm not a heroin abuser and I can't always connect with them, it's important to have a sponsor, a recovery coach, we call it, come in and speak to them directly, say, hey, I know what you're going through. I've been there before. Look, I'm now clean. I've got my life back. I'm working. I've got a family. I'm reconnected with my family. They give these patients the hope that they can make it through, because often there is no hope out there for a lot of them. And many of them are now homeless. They're living on the streets. You'll see them panhandling downtown and here in the county as well often. And so the recovery, we make the call, the recovery coach comes in, and we then connect them within a day or two to a substance abuse treatment center. For us in the city, it's Queen of Peace, it's Comtria, it's Preferred. We have a small clinic at BJH, and then there are the private clinics that are around as well. And so getting them connected, because when we treat them today, they need treatment for the next months or sometimes even years. And that's what's going to work. And also, one unique thing that we do, and we realized, we didn't have the physicians that were able to prescribe the Suboxone. Suboxone works because it attaches to that addiction center in your brain, and it relieves it. It doesn't give you the big high, but it relieves it. So when we get the Suboxone in the patient that we just gave the reversal medicine to, they don't want to run out and go shoot up. Most of them don't want to go back out and shoot up, because we've given them something that settles that addiction, that drive that they can't really control. And then they have a sponsor, they have the recovery coach that they can call, and they follow up within a couple of days. And that's crucial to really getting people engaged in the treatment and keeping them engaged. People that are on Suboxone, even if they continue to use heroin, are less likely to die, because Suboxone contains a little bit of the reversal agent as well, the naloxone or the Narcan. And so people on Suboxone actually are less likely to die, even if they do continue the heroin. Hopefully they don't, but sometimes they do. And so you'll see here, this is up until today from we really started, we put together the plan, we operationalized it, started to operationalize it in December 2016. By January, February, March, we started enrolling patients because we wanted to get this treatment and this process to the patients that needed it. And you'll see our referrals, this is by hospital in our region, so you have Barnes, SSM, DePaul's up there, Mercy, Christian, but by far at Barnes-Jewish Hospital, this is just for May, so last month, we referred 90 patients. And we could probably get up to 150, 160, but sometimes in the emergency department we get distracted, the patient leaves, the patient doesn't always stay. But my goal is to get that up to 150, 160 referrals at least per month. But we're at least up to 82, we've made great strides, but look at our other hospitals. And this is why we have such a high death rate in our St. Louis region. There's not a lot of referrals, there's not a lot of treatment going on, especially with those most in need. So it's typically the uninsured, because a lot of our opioid abusers have lost their insurance and they don't have a job. And so nobody is really paying attention to them. But now we're starting to pay attention. And you'll see for the total project course so far, we've referred 1,262 patients. So of all the referrals in our St. Louis Eastern region, we've referred at BJH about 40%. So we're still the leaders. We have a lot of work to do with the other hospitals and emergency departments. And this isn't just for BJC. We want to solve the problems in our community. So we've got to bring it out to SSM and Mercy because we work as a team for the health of the region. And then you'll see here over time, this is the number of patients we've referred and gotten into treatment. And we go through ups and downs, and it depends on the number of patients we're seeing, of course. But you'll see that we've got a steady climb upwards and over the last 2 years. This isn't something you can instantly turn on. Plus, we didn't have a lot of resources to operationalize this going forward. The good thing is the percentage of patients who are referred who agree to go into the program are high. We have 95% at Barnes-Jewish Hospital. Christian has 93%. PSC is our Psychiatric Stabilization Center. We have patients with behavioral health issues that need to be admitted, and then we're connecting through PSC or the Psychiatric Stabilization Center over on Del Mar. And then we're looking at, this is starting the Suboxone, which actually is key, I believe, to keeping a higher number of patients engaged in this program. We really have to do it from the emergency department or get it to them as soon as possible as we reverse the effects of this opioid or the heroin. And you'll see at Barnes Jewish Hospital in the emergency department, of the patients that had MAT initiated, and remember, we've seen 3,300 patients over the last 2.5 years in this program. Only 429 are getting MAT. So that's the Suboxone, getting the Suboxone, only about 13%. Really, that should be closer to 90 or 100% if you want great success and to prevent the deaths, lower the deaths in our region from this, get people into treatment. So we have a lot of work to do. And so we at BJH have given, of all the MAT prescribed in our area in emergency departments, 71% of it is done downtown at our urban emergency department. The problem with MAT is we weren't trained to do this as physicians. It's not in our education. We have to go through extra training for it, and a lot of us are, who else is doing it? And then maybe I'll jump on and get it. And if I do get wavered, is everybody going to come to me? All those things people worry about. But this is really like treating diabetes. It's like treating cancer. It's treating hypertension. We've got to get rid of all those biases, and we have to start getting the treatment to the patient and not be afraid of getting the treatment to the patient. And so it's wavering. Of those 55 physicians in St. Louis City, 20 to 25 of them are from our emergency department right now. And that's because we've been encouraging our faculty to get waivered and to get trained. In the Barnes-Jewish Emergency Department, we make up half the MAT prescribers in the city itself, which we really need. And so our goal is, and we'll talk about this, and Laura will talk about this, is how do we get all the physicians to be able to prescribe this? And so did you want to
Sure.
talk about the inpatient treatment?
Sure. So as
One other quick thing.
Yeah.
So one other thing, sorry, we wanted to go over. So when the recovery coach comes into the emergency department, the patients receive this. This is an opioid overdose rescue kit. I'm going to distribute this so you can take a look at it. Evan has one as well. What's in here, we've put these together with our local nonprofits. And there's a nasal spray. This is Narcan, so you just open it up, you give a spray, and then so a person that's not breathing, you put this in their nose, you push the button there, give them a spray, and they'll wake up within 30 seconds to a minute. So there's 2 of them in there. There are instructions. There's even a little valve if you need to give them mouth-to-mouth for a while. If you want to, you can use a little protection valve. If you don't want to give mouth-to-mouth and they're not breathing and their heart's not going, just give CPR for a while, just the hands-on compression, and give them a spray. But that could save their life. And then there are some other resources. So we'll distribute these so you can take a look as well. And then Evan's going to.
Sure. So as much as we're talking about in the ED, we also decided we need to start treating patients on the floor. So the toxicology service and the psychiatry service have been committed to treating these patients in the hospital. And what you'd find is there's lots of patients in the hospital that have an opioid use disorder, an opioid addiction. On the extreme end, we have people that come in because of an infection from using opioids and spend 6 to 8 weeks in the hospital, literally just receiving antibiotics. And the mainstay would be to give them antibiotics as long as they'd stay in the hospital, and then discharge them without treatment, and then somehow be surprised that they came back sick again. And when you're talking about the hospital being full, imagine if we had those 30 beds back all of a sudden. And that's just the long-term patients, not even the patients that are only there for a day or two. So we started treating these patients in the hospital, and we looked at patients that required an infectious disease specialist to see them and required at least 2 weeks of IV antibiotics. They had an opioid use disorder and opioid addiction, and we looked at patients that the teams got a consult on with the addiction medicine service, which was psychiatry and toxicology, or patients that did not receive an addiction consultation. And as you can see, if an addiction specialist came and saw you and started you on medicine, so Suboxone or methadone, you were much more likely to complete your treatment, so 80% to 40%, and much less likely to just leave the hospital in the middle of your treatment. So they actually stayed and got their whole treatment. And then most importantly, they didn't come back, and they didn't come back really sick. So they actually did better once they were discharged. They didn't immediately come back. And our ICUs are full. It's hard to get a patient in our ICUs. So not only did patients that didn't get medicine and didn't get a consult come back, they were much more likely to use the ICU. So nearly 90 days these patients spent in the ICU when they got readmitted versus about 10 days. So it was a huge amount of beds that opened up and saving money on that end too by simply treating them in the hospital. And so you can go from before where this patient was despondent and couldn't get help to hopefully turning their lives around and getting them back to their family.
So I'm going to.
Oh, every patient in the emergency department that gets connected to the EPIC program. They do distribute them at a lot of the substance abuse centers as well. We encourage, you can buy the kits. We encourage people to keep them in their cars or in their homes.
And actually, anyone could purchase the reversal now without a prescription. So parents could purchase it at the pharmacy without a prescription. And that's been one of the kind of public health policies that's gone on there. So I'm going to take a different point of view. My career has actually been as a physician scientist looking at the genetic underpinnings of addiction. And we've been very successful identifying different types of genetic variants that predispose people to heavy smoking, alcohol use, a variety of other drug use. But as my career has gone on, I've been taking this step back to look at kind of how do we implement the incredible science that we have? how do we move this really from, you know, the bench to the clinical care that we have? And my view of addiction is actually many steps before an individual comes to the emergency room with an overdose. So I think of addiction, you know, starting from the initiation of the drug, the movement to regular use of the substance, then to misuse, then the opiate use disorder, overdose, and death. So as I kind of look at this cascade of events, moving from initiation to misuse to opiate use disorder, I think that what we're having is a failure for us intervening at these earlier time points and really kind of stopping opiate use disorder from transitioning to the overdose and death. And so though we need to really be moving very hard with every patient who comes in with opiate use disorder and an overdose, we need to also be thinking about these earlier steps going on. We need to think about what is the supply side for opiates in the general population. How do we identify individuals who misuse before they've transitioned into opiate use disorder? And then how do we prevent overdose amongst those who we've identified with opiate use disorder? So the National Academy of Sciences just came out this past spring with basically a playbook, how we should be confronting the opioid epidemic. And we are contributing to this and following this type of playbook. So what we know is most people with opiate use disorder are interfacing with healthcare systems. They're going to primary care providers. They're in the hospital. They are receiving, going to emergency care. Yet we have this terrible leakage of these patients. So instead of capturing them as they've been interfacing with the healthcare system, they're leaking out of our system. We historically would just give them a piece of paper, say, you know, call this type of treatment center. And that is not really adequate. And as we've been working with BJC, our groups, Clay Dunnigan actually gave the best line, as I've been the mantra I have is, we should not let the sun set on anyone with opiate use disorder without connecting them to treatment. So the same way that we have protocols that if someone has a stroke or someone has a heart attack, we have time limits that we want to get these individuals in treatment. We should be approaching the opioid epidemic the same way, that we should be making sure that they are connected, engaged in treatment, and on this path, and not just kind of letting the system, you know, just figure out what it's doing on their own. We need to implement this in a very precise and efficient manner. And so this past fall, we, as some of you may know, we applied for a large project called Healing Communities to try to reduce the opioid epidemic. Unfortunately, we were not successful, but what it did was it allowed us to build this model that we're calling the no wrong door model. What we know is individuals with opioid use disorder are really affecting so many different aspects of our system. They're interfacing with behavioral health centers, the mental health clinics. They're in the hospital and the emergency department. The justice system is having, you know, tremendous amounts of issues with people with opiate use disorder. It's hitting the public health departments, and it's hitting our foster care system. And then there's the academic institutions that we have. So our model of this that we're really moving forward is a person-centered model of when they are hitting these different systems, how do we identify a person with opioid use disorder, and how do we connect them into care? And we should be doing this through all the systems. Yes?
I have a question. How do you step back? What's the step before they get to the opioid, you know, the opioid disorder? I mean, what's the step before that?
So as I would think about it, this opioid crisis has in large part been driven with the tremendous amount of opioids that we've been prescribing over the last several decades. So we need to change our policies and our approaches to prescribing opioids.
So it's the medical community really that is the step before we become these opioid crisis people.
Yes, so we have been part of the problem. And actually, the opioid crisis that we've had, this is about the 8th opioid crisis that the United States has had. And we cycle through these. The first one was after the Civil War, and it was called the soldier's disease. And often what's happened is individuals have terrible pain. These morphine is around. You have this prescribing increase, and then it transitions into the different disease. So yes, we have been part of the problem, and we have to take responsibility for that and change the system, change our prescribing patterns. So I want us to, this really is
Laura,
kind of,
there's a couple.
oh, yes,
Can I just kind of respond to her?
absolutely.
A big part of the problem is you don't know that you have a problem. You don't know you're going to have a problem until it's a overwhelmingly life-threatening problem. It could be anybody in this room who has a car accident on the way home tonight, and you might be put on strong pain meds, and you don't know you have the disease because you've never really had to take those medicines before. And you're on them, and you're on them, and you're on them. And then if you have that disease in your brain, that would be you.
Mhm.
You could end up in the emergency room or dead.
And it's,
Very difficult.
it's very difficult. It's a very difficult system.
But do you necessarily have to have it? I have alcoholic friends. I drink a lot. I don't think I'm an alcoholic, and yet their brain wiring, they are. But my understanding is with these opioids, if you gave them to just, a normal person with terrible pain, all of a sudden you become this opioid addict.
So not everyone responds that way.
Can you repeat?
So the question was, does everyone become addicted? I think it's kind of, does everyone respond to opioids the same way, and does everyone get addicted? So again, there's been this whole issue of, we have increased our prescriptions of opioids. If you look over the last 20 years, opioids have been prescribed much more widely. But not everyone responds the same way to the opioids. And that, some people, and you don't know, we don't have that ability to identify individuals beforehand of who is at risk for transitioning to dependence versus who's the person who could take the opioids and then get off of them easily. Is there a question in the back?
Yes, Dr. Bierut, your chart earlier talked about initiation.
Yes.
And initiation, in terms of the two questions, two line of questions, is where the prescription might be written to initiate the patient on the opioid.
Yes.
Two questions. One, based on the past statistics, how many tablets or how many doses of opioid one has to take to increase the likelihood of addiction? And the second related question is there something that is holding our hand that anybody who gets beyond that number of pills, we basically put the system, give them both the information about the addiction, but also put them on the watch list.
Right.
So their primary care physicians or others are now informed about and looking carefully about the signs and the possibilities.
So the question was, the initiation and, what type of dosage do you see before people transition, and what kind of are some of the symptoms that we could identify afterwards of thinking where a person is with the addiction. So, so what we know is that, I'm sure people have been reading in the paper about the different types of lawsuits that the states are taking against some of the pharmaceutical companies about prescriptions. So we have prescribed more than what was historically done. And in general, people would say a 3 to 7 day prescription should be the limit for an opioid prescription. What we know is if you are on an opioid for 30 days, your likelihood of staying on that opioid over the next year, so if we kind of see you again in a year, it's about 80%. So it's very quickly that people transition from the short-term use to the long-term use. And the other aspect that's out there is opiates are amazing drugs, absolutely amazing drugs for acute pain. But chronic pain is something else. And there is very little to no data that opioids are effective for chronic pain. And so, again, there was a whole series of things came forward that got us into this crisis. And now our goal is, how do we get out of it? So I'm going to put this up here of how we've been conceptualizing what we've been doing over the past year with this substance use disorder. And what we have at this institution are incredible areas of excellence. You know, the emergency department, the psychiatry, internal medicine, OBGYN, all of these groups are now really starting to approach the opioid crisis. And as we've been thinking about it is, we need to do the classic 3 aspects of what an academic medical center does: education, research, and clinical care. So I will just mention briefly the education, and then we'll kind of all open it up, because I'm very pleased that about 10 days ago or so, we applied for a grant to make it so that all of our medical students have this specific training for the X waiver on graduation. We are extremely pleased that all of our medical school graduates will do this. We've gotten support from our Dean of Education to help us with this. And we've also gotten support from several of the different residency programs that all of the residents will be trained in this, with this X waiver. So all psychiatry residents, all emergency medicine residents, and we're very pleased that all internal medicine residents will be trained. So this is, I think, one of the things that I'm extremely pleased about, because we have to kind of change the system, and starting with education is one of our key points. But I will kind of open it up to questions, or if you guys want to talk about any of the aspects.
Yeah. So just a quick, so our goal is to create the center of excellence. The education is crucial because we have to get it to the medical students, the residents, the fellows. Any one point in time, we're training 1,000 resident and fellows downtown, and then we've got another 200 or 300, if not more, medical students. And so we need to attack this problem on multiple fronts. You've got to hit it from the prevention before it even starts, and then we've got to target it in the center while people are getting addicted and how to prevent that. And then once they're addicted, we have to get them treatment. Otherwise, they've got a high likelihood of dying. And we need to, we've got a crisis, 50,000, and some of the recent data says 75,000 people in the US will die this year from opioid use disorder. You're seeing it on 60 Minutes. And other news segments. And so all 3 are key here. We don't know exactly what we need to do for all the preventative things yet with addiction, and that's where the research comes into place. We have to also not only educate our physicians, we have to educate our staff, the nurses. We have to educate the community as well, and those who are prone to addiction and those who are not addicted, and families. We need to educate families, hey, your loved one who has this opioid addiction still needs your love and support. We've got to work with them. We've got to get through this. You're part of the treatment as well. And so we have to get that education out. And then the clinical care, navigating our healthcare system, even if you don't have opioid use disorder, is still tough. And so providing navigators to this population who already are not thinking clearly is crucial to keep them engaged and get them the treatment they need. Social workers are vitally important. Integrating all the services that we're providing from all aspects, definitely crucial. And we're not great at doing that, but we think a center of excellence will help us formulate that and bring everybody together. It's like planting a seed that grows into a large tree, and it spreads its roots and its leaves everywhere. And then telehealth is, we know we have issues. So right now, the EPIC program has expanded to Columbia, Missouri, to Kansas City. What we're doing here is unique, very innovative. Not a lot of places in the country are doing this yet with the EPIC program and getting patients Suboxone right when they overdose, or working with any of the preventative efforts that are out there. And in places where it is happening, it's being done in minuscule amounts and nowhere near the amount of coverage that we need. So in getting into the rural areas is what we're having difficulty now figuring out, but we think a solution will be telehealth. We can empower the clinicians, the medical people in those areas, and we can also do it through telehealth. If they have nobody waivered in their area, which probably 80% of Missouri, there may not be anybody waivered. So through telehealth, we can provide access to somebody that is waivered, teach the medical community in those rural areas how to provide this care, give them the confidence they can provide that care. That's going to be crucial to exploding this out throughout the region and throughout the country. Personal devices, if people are willing, will help keep track and tabs on patients. You can watch vital signs. You know, the new watches now watch your heart rate. If your heart rate drops to 0, maybe it sends out an alert on these on opioid use disorder patients, and then we know to get them, try to work on getting them immediate help, or people around them contact them and say, hey, use that Narcan kit we gave you. So looking at personal devices, so there's a whole host of things that we can bring out there and try to combat this problem.
Sure. I guess we'll take questions and kind of just have a conversation about things.
So with the available treatment centers, are there enough of them to accommodate the people who need it here? Are people turned away when they really need it? And if they can't afford it, how do they?
So yeah, there's not a lot of what we've been able to do getting people into treatment in these outside communities is all from the federal money that's being funneled into the state. And every day when I talk to the people, or when we talk to the people in charge of it, their number one nightmare before they go to sleep is what happens if the federal government decides we're not going to stop funding these places. Even with that, while we've been more successful getting people in once they come to the hospital and once they overdose, as Dr. Bierut mentioned, you know, that's waiting until something happens. When you identify them in clinic as an outpatient and try to get them in, it's still really hard to get these patients into treatment.
And in some ways, we're thinking of a different model of treatment. Instead of having this model of you go to a treatment center for addiction, we're thinking of doing it as point of care and integrating it into primary care. And that's going to have to be the model, because we don't have enough providers. If we just ramped up all the providers now, today, we wouldn't have enough providers, and we can't wait.
Laura, I know your expertise is in addiction. Why overdose, and especially why fatal overdose? Is it just that you can't tell the concentration of medication? Because there has to be a level that satisfies the addiction, but then why go over it?
So my short answer is going to be, there's been changes in what is in the drugs that are purchased now. And in particular, fentanyl has been added, which is incredibly potent and has been leading to these overdoses. So
people just don't know that they're getting that?
Yeah.
yes.
When you look at studies and they've asked people after they've been revived, what do you think, were you trying to get fentanyl? A lot of them were like, that was not my goal with this. I thought I was getting the same thing I'd been using for the last 15 years, and it was this extra super potent drug that they got instead.
How does it get there? Is it the dealers do they make more money by
Yes, they make a lot more money.
And it's more concentrated, so it's easier because it's a smaller volume and a bigger high, so you're able to transport it much more easily.
Yeah, and we've seen people stop injecting and they have a clean period, but then they go back to their old dose, which you build tolerance over time. So they use their old dose when they really should have halved it or reduced it dramatically because they've been clean for so long they lost their tolerance, and then they'll stop breathing.
Yes?
Two questions. On this X variance, I don't know if I explained that right. Who grants that? And why do they limit it to only 30 patients a year when the need is so great? That's question number one. And question number two, if you told surgeons or whoever that are giving out these opioids that you get 7 days, that's it. You have to jump through all kinds of hoops to go over 7 days. Would that be accepted, or would that be rebelled against?
I'll take the 7-day question.
Okay.
Do you want to do the X waiver?
Sure. So it goes back to a law that was passed in 1914 that made it, literally passed in 1914, that made it illegal for physicians to treat patients with opioid use disorders with opioids. So there had to be legislation to allow methadone, and then in 2000, the Data Waiver Act, which was finally we could use buprenorphine in 2002, but actual federal law that said, okay, you can use buprenorphine, Suboxone to treat these patients, but in there they also made us go through a bunch of hoops. So it's actually the DEA. So it doesn't happen as much as it used to be, but there's stories, 14 years ago that DEA agents would actually go into people's offices and say, and shut the door and kind of lock everybody in there and say, let me see your log of the patients that you're prescribing and evidence like that. So that stuff has really gone away. The stigma from it still exists, but it's federal law that still handcuffs us.
So the 7-day prescription. So actually, a lot of the pharmacy benefit programs, like Express Scripts, is now limiting prescriptions for new opioid prescriptions to 7 days. And they just will not fill more than 7 days. And what they found is, and historically it would be the surgeon would give you a 30-day supply, just, give you a lot. And many of us probably have opioids in our medicine cabinet when, you could just get this big supply. And 97% of people get that 7 days and don't go back and ask for any more. So it just shows you, how much of a great supply side was out there.
What about the 30 patients? What's the reasoning behind it? If you get the X variance and you can treat these people, you only get to treat a maximum of 30 in a year.
I think it had to do with concern about
Yeah.
Doctors making patients addicted.
It's the stigma, right? Because if I want to prescribe oxycodone, no one has ever limited how much I wanted to prescribe.
Right.
Day one of my intern year, I could have written the most ridiculous prescription for oxycodone in my life. And maybe the pharmacist would have said, are you sure you want to do this? But that would be about the only blockade.
And so it is this funny thing. I think that every physician needs an X waiver to prescribe an opioid. And everyone should be able to prescribe buprenorphine with no problem. But that's not how the policy is set up.
Yeah, Suboxone is an opioid, you have to be careful, but we know that Suboxone works well to treat the addiction and to prevent people from going out and using the heroin and overdosing. So that's, we had some European data up there. Europe has actually solved a lot of this problem. We just need to bring it into the US and have the resources to enact a lot of the solutions that Europe's already enacted.
I just want to laud you because I think the program, the EPIC program, and what I've heard tonight is just, dealing with the people already having the problem, and then more to the prevention side. And I'm so happy to hear that you're on the side of, I know that when I had surgery, the doctor prescribed an opioid, and I vomit. And so I told him, no, I don't want it. But he said, no, and I had a 30-day supply. Fortunately, I knew how to get rid of it. But my husband, who passed away, and he was part of hospice, when he passed away, there was morphine that we had left over. And the hospice nurse said, we can't take it back. Now, I knew to take it back, but I think maybe some more information to how to get rid of just because I had a teenage son, and I know I heard stories at high school where they would raid medicine cabinets, and for older people, they figure, oh, they probably have stuff in their medicine cabinets and they can get access the initiation phase for them. And also, I'm so thrilled to see the medical students at WashU getting trained. I think that's wonderful because I think there's very little in pain management. The first thing physicians think of in pain management has been, in my experience, an opioid, whereas there's so many alternate, even non-drug, non-pharmaceutical. And as I mentioned before when you were talking, I'm from Canada, and my uncle who died of cancer was prescribed CBD oil, and it worked, and there were no constipating and vomiting side effects, and you know they're getting more knowledgeable up there. So I'm hoping there's more research with all that. Wonderful presentation. Thank you so much.
Thank you.
Are you planning on expanding out to West County, Lawrence, and Lobap?
Yes, so we're working with the Center for Clinical Excellence, the CCE at BJC, to expand it to all the BJC hospitals. Amanda's here, who's leading a lot of our efforts over there. Missouri, so the governor and Randall Williams, who's current head of the Department of Health and Human Services for Missouri, we're trying to expand EPIC statewide, but the state doesn't have a ton of money for it, and they're dependent on the federal funds. The federal funds right now are only guaranteed till the middle of next year, and it's probably not enough to expand it out fully, but there are plans to continue, and EPIC is spreading. We're working on some rural initiatives in the state with the state government. And in terms of, we are lobbying to overturn these what we think are archaic rules of only having 30 patients. You have to work at both the state level and then the federal level. So through our organizations, we're lobbying. In fact, we were in DC this spring and talked to all the senators and reps about it, and they seem to be on board. But it's just getting the education out there and continuing to work on it. And it's going to take us all. So
we're putting together, oh, sorry.
I was going to say, and we are working with the St. Louis County Department of Health. So we have been really quite engaged with them. And St. Louis County has been a leader in this with their prescription drug monitoring program and a lot of aspects. So St. Louis County has actually a nice program in place that we're working with them to try to implement.
And we're currently putting together a proposal for MOVAP to actually, with telemedicine, get more addiction medicine out there.
So back in the 70s and 80s, due to leg hip complications, I had to have painkillers, and I also had numerous surgeries, but I never felt addicted. But so is it my understanding that some years ago, there were stronger painkillers approved by the FDA, which is, now prescribed, and if so, is the trend line for these addictions increased since the time of those stronger painkillers? And then the second question will be, or third question, depending on how you're counting, will be, can those newer painkillers be removed from the market?
So I'm going to start with just the different types of painkillers out there and that aspect. What we really think is it's more been the supply side of the amount of painkillers. Would you say that it's really, it's not as much that the different formulations, and again, some people are able to tolerate it, stop, no problems, others don't have that. And so I don't see, well, there is concern now about the different types of approval for the different opioids. I don't know if you guys have been seeing some of that, if you want to comment.
Yeah, so there has been at least one that was removed. There was pushback to a hydrocodone type of long-acting derivative that was going to be put out there that people didn't think that there was good use for. But there is this, for instance, fentanyl under the tongue medication that makes a whole lot of sense in a battlefield to have, but makes little sense for kind of post-surgical pain or hospital pain that just got approved. So it's kind of all over the place, but with effort, you can get some of that genie back in the bottle.
Yeah, there's a lot of illegal production and distribution of opioids out there. And the patients would tell me, I said, why are you using heroin instead of the Percocet or Vicodin you can buy on the street? They're like, oh, the Percocet and Vicodin's $10 or $20 a pill, but the heroin now is I can get a button or for $3 to $5. So then they would switch to whatever they could afford. Andy? And then,
yeah, I take a different approach here with doctors being reluctant to prescribe the medications now. As I mentioned to you and Dr. Tonder earlier, Linda, who has the flu bug this evening, was treated for triple negative breast cancer, which is a high-grade, life-threatening type of cancer. And she is clinically free of disease now, but she is on a website of women with similar disease. And I said, tell me some stories that you've heard on that website. She said, what's terrible is that women with metastatic bone disease with extensive pain have physicians or beg physicians to prescribe the optimal pain medication, where the physicians are reluctant to prescribe narcotics. And in fact, there was one statement where the doctor told this terminally ill patient, we're afraid you might get addicted. So maybe to pursue this in a psychiatric way here, what can a patient like that project guilt-feeling to the physician when they're requesting optimal pain medication?
So, I think you bring up this conundrum that we have, and in particular, the patients with cancer pain was the motivation for us to increase prescribing opioids. And I think that all of us would say, this is a nuanced issue here of we don't want patients to have pain, but we also have to be very careful about this aspect of addiction. So we've moved from the patients with cancer to giving so many different opioids for so many different aspects. And I think that we would all agree that patients with cancer who have pain should be treated to relieve their pain.
And that goes back to kind of this model with education, because really it's educating. There's a difference between someone who needs this large amount of opioids, and if you stop them, they're going to get sick because their body's used to it, just like if you stop their blood pressure medication or stop their insulin, versus someone that has an opioid use disorder, which just because you're on opioids doesn't mean they're not the same thing. Dependence doesn't equal addiction. So it's education here to help people understand the difference. Both physicians and I've had patients in my clinic come up to me thinking that they're addicted, and I'm like, no, you have cancer or you have sickle cell disease, and you actually do benefit from some of these opioids, and this is just normal, you're not addicted to them.
And research into alternative treatments of pain are very important because there's a psychosocial component to pain as well, and the brain is very powerful at controlling what you sense as pain. The industry is starting to produce more non-opioid pain treatment because we don't have many out there. We have Tylenol, we have ibuprofen, and the various forms of all the NSAIDs, but we don't have a lot else out there. So I think it's going to spur more development and research on non-opioid pain controlling medications.
So can I bring up the question we were asked before, which
Sure.
I'm often asked? Would you rather have a patient on opioids with chronic pain, a patient with chronic pain on opioids or marijuana?
I would probably prefer marijuana. Now, I think one important nuance in this is there is some thought out there that by giving anybody marijuana, you'll eliminate all these opioid deaths. I'm not sure how true a lot of that is, so be careful with that. But yeah, I mean, marijuana is far less dangerous than, high doses of opioids.
Do you have an opinion?
Yeah, I would say, I think it's tough right now because with marijuana, there are some good attributes that you hear anecdotally from people that use it often, but it can also be a gateway drug as well. And so what box are we opening? And we've already seen data out of Colorado, the states that have legalized marijuana, more emergency department visits, and there are a lot of adverse side effects, more car accidents. The death rate from car accidents in Colorado recently has started climbing for the first time in however long, due to probably the increased use of marijuana. And so we have to be very careful how we play this game out. We're not going to be able to change it, but once you open up the box, you don't know what's coming next. So.
But there's good data that the states that have legalized their opioid death rate has gone down. So, I mean, this is, boy.
But aren't we talking about medicinal marijuana versus just regular marijuana?
So the problem with medicinal marijuana is, what is medicinal marijuana? Because there's really no regulation about it.
And when you, in states that have gone from, for instance, medicinal to recreational, adult use, whatever you want to call it, the medicinal market generally goes very far down because now people don't need that. They can just go purchase whatever they want, which has had some other unintended consequences for people that had, for instance, some neurologic disorders where there is some evidence that it may help, and now they can't kind of get the products that were helping them.
It's going to be so interesting.
There was somebody in the waiting for him.
How long is a patient expected to stay on Suboxone? And if they, in some ways, aren't you just replacing dependence on one drug with dependence on another drug?
Right. Can I take that one?
Go for it.
So the question is, how long should someone stay on the medication-based treatment, so like Suboxone, and is it a substitution for one addiction with another addiction? So I'm going to, so there has been this kind of thought out there of the substitution of one addiction for another, and I think that that's just something that we have to kind of fight. And the whole purpose of these medications is to get someone functioning with their family, functioning with work, functioning in society. And what we know is these medications that are monitored get someone to do that. So there's also a lot of controversy of how long should someone be treated. And I would generally say we treat someone as long as they need to be. And with the methadone, people have been treated for years. And I would say clinically, if someone is doing well, before we remove this medication, we have to think, are you going to relapse? What is the likelihood of relapse? Because we want someone as stable as long as possible. So, one of the areas of research that my group is doing now is looking at these large data sets with 100 million people in it with the pharmacies to see what's the trajectory of people who are treated a long time versus short periods of time. We're looking at things like, do we treat teenagers? I mean, isn't that kind of scary to put teenagers on some of these medications? Their brain is still developing. Should we let them try to go into recovery without medications, or should we be more aggressive and treat them with medications? Because they're in that trajectory where they're trying to, go through high school, go to college, get their career. That's such a clear developmental period. And the data that we're seeing again and again is the treatment with these medication-based treatments people have better outcomes. And to me, that's the outcome that I want to see. And that gives me the answer.
And that's the real key difference. If I'm on heroin or I'm on Suboxone, they're both an opioid. When I'm using heroin, I'm at risk of death, I'm stealing, I'm not working, I'm displaced from my family, I could contract HIV, hepatitis, all these bad things. When I'm on Suboxone, I'm still on an opioid, but I'm not at risk of overdosing, not at risk of HIV, hepatitis, heart infections, I can get a job, reunite with my family. So yeah, they're both on an opioid, but one, their life is hopefully back to where it should be, and the other, their life's in a horrible place.
Is there a difference between those states that have Medicaid and those that don't, like Missouri, in terms of its effect on the ability to get the kind of drugs you need versus the street drugs that you don't need?
Yes.
And actually, one of the major critiques when we put this application in was Missouri was not a Medicaid expansion state, and they did not think we would be able to sustain the program we proposed.
We'll take one more
All right.
question and
Yeah,
then.
please. I'd like to mention the fact that there's kind of an elephant in the room. This is a foundation event. I'm one of the few physicians who's proud to be on the board of the foundation. This means I'm going to lean on Bob Cannon for a response to this.
I didn't get up here soon enough.
all of the really phenomenal things that you've covered this evening, this is a foundation event, and people know that there is a foundation. What I think is important to get the point for all of us is that because of our position at Washington University Barnes-Jewish Hospital, we're talking about looking out for the entire community. And I know from information shared with the board that Barnes-Jewish and BJC have just made even more commitment with the medical school to helping the community, especially the underserved. Bob, I don't have the right words for this, but this is, I think all of us here tonight need to know that in addition to taking care of our own patients and doing the things that we do and doing our research, there's a huge commitment to the overall community. You're supposed to say something.
So I'll say a couple things. One is that the Ira is right. We have launched a bold initiative starting this year around community health improvement. And there are, for those of you who've been in the St. Louis community a long time, you've heard this before. You've heard the leading institutions in our community talk about community health improvement and the needs of our community and what our community is crying out for. This time it's going to be different. We have an alignment that we've never had before. We have a set of needs in our community that have become so acute that on almost a daily or weekly basis we find ourselves in the national news, and not in a good way as a community. And so the leadership of BJC, the leadership of the School of Medicine, the leadership of the university, the leadership of the business community in town, we're coming together in a very different way. Here at the foundation, under the leadership of the board of the foundation and Susan, we have now created something called the Healthy Futures Fund. And this is a new opportunity to engage all of you in giving in a way that will be directed toward the health disparities in our community and toward the types of issues like opioid abuse that we're talking about today. So this is our turn, and this is our time to make this kind of difference in our community. So being here tonight is part of that, but when we leave the room, there is much more to do. So Ira, thanks for that opportunity to say a bit more. You know how passionate I am about this, and I know how passionate you are about this. So thank you. Susan?
And we're all passionate about it. Thank you so much for being here. We're going to wrap up this portion. I know there are still more questions, but I do want to thank you so much and thank our presenters. For being here, but for doing what you do, because truly you are leading and you are supported by those of us here and so many in the community, and we appreciate all that you're learning. Did you see that graph? Barnes-Jewish is leading there, and as we should, and together we can make a difference. So I know you have more questions. We'll be here, for another good half hour that we can fellowship, and you can continue to ask questions, and I know the doctors will be happy to talk with you more. My commercial is this: check us out, the foundation, on our website, and if I say this correctly, follow us on Facebook, and follow us on Facebook. I don't know.
Do you tweet?
I don't tweet. I don't tweet. He tweets. But follow us and check us out and see that the impact of your support and how it is truly helping our community. Thank you so much for being here.
And we're here to answer any questions. So,
They are fabulous.
I lost my place. Follow us. Oh, and like us.